Thank you for inviting me, and now that my peptic ulcer is fixed and I don't have any bile leaking anywhere, and I think I've got all my counts in and out for drains, I think I'm ready to go home as a patient. Or am I? So when we travelled to Canada and America in 2012, we looked at risk prediction tools, and essentially these are on a medical model, but I can't see why they can't be adapted for every patient that comes in our door. So this is hot topic at Department of Health everywhere at the moment, representation and readmission rates. And you might think this is purely medical, but I'll turn the page in a minute and see that it's not. But before we went to America, Ballarat Health had a representation rate within 30 days of 17%. It's very hard to find this data, and I had someone search through a lot of things, and they're telling me now that it's about 19.5%. Why this is, we're seeing increasingly complex patients, and everyone that's spoken already has spoke about the comorbidities in these surgical patients that you're treating. The variance in clinician skills regarding discharge planning and the service fragmentation in regards to program silos and the lack of follow-up in the community. One patient had seen 2 different hospitals, I heard someone say earlier, and 2 different surgeons, and was lost to follow-up. Barriers to access to primary care, GPs, long waiting lists for outpatient departments. So that's what sort of initiated us to head over to America and Canada and have a look what was happening over there. So we're currently exploring the use of a risk prediction tool at Ballarat Health. So the main targets of efficiency have it been essentially in reducing your length of stay. You talk about improved surgical techniques and decreasing these non-acute admissions. We're seeing increased chronic disease and an ageing population, and the aiming to prevent the unnecessary acute readmissions and representations in these cohorts. So they say that if a patient experiences a preventable readmission within 30 days, it's likely to be an indication of a poor care transition. So perhaps focusing on readmissions in the shared care is about improving those care transitions. So the problems with readmissions, Scott tells us that 3 to 11% are readmitted within 30 days of discharge, and 90% of these are unplanned, and 80% relate to acute medical complications. And it's the lack of standardisation in the discharge process that might predispose us to poor outcomes. So who are these people? COPD, chronic heart disease, neurosis, recent vascular surgery. Those that are isolated from lower socio-economic groups, impaired cognition or functional decline, and most of them are men. Previous long hospital admissions, poor communication within the health team, early discharge of the patient, and those that are not prepared for discharge, ones that families or community services haven't been involved with, who's going to do that post-op wound care, who's going to follow up in those regards, and inadequate community follow-up. So a risk prediction tool, big deal really. What is it? Is it an ability to identify patients that are at increased risk of readmission? They're not going to be a godsend for all of us. They're not 100% accurate, and they're not to be used as the sole method of identifying someone that's at high risk. The ease of implementation of these tools depends on the tool. England are using a tool called PAR, and we saw that used in New York, and it's really quite complicated and old computer-based data. So Carl van Welraven in 2010 and his team in Canada aimed to identify a tool with 4 derivatives that would actually accurately predict readmission or death post-discharge within 30 days. Now I just thought, because we've seen so many words, we'd have a picture of our lovely outback, and for those that have been to Cameron's Corner, you'll identify that there as the first photo. I threw these in because I just wanted people to think about change, and we might be very keen to make change for change's sake, but back in the late 1800s, early 1900s, they built this great big 5,000 kilometre long dingo fence to keep the dingoes out of the sheep country in New South Wales. Now you might think, what the heck? But they wanted to make change. They did make change, but it wasn't the outcome that they thought they would make. By reducing the dingoes in the sheep country, the foxes were able to overpopulate and then decimate the sheep populations there. So change isn't always good, even though you might think it is. The next one is the Culleyamurra waterhole on Cooper Creek. Robert O'Hara Burke perished here in 1861 on his return from his epic journey because he didn't want to change. He didn't want to adapt with the local environment. He didn't want to mix with the local population. John King survived and was rescued. But I just wanted to say, adapt, change, look at your local population, think about changes or perish. So those four variables that Carl Van Raven came up with and his team was length of stay, and he scored each variable and you end up with a total score of 19. The second one's acuity. Were they elective patients that came through for elective surgery, or were they emergency patients that came through the emergency department? The comorbidities of the patient, the Charlson's Comorbidity Index, and that gave them, and the emergency departments in the last 6 months, so those that represented to the emergency department, that gave you a score of 19 or less. They consider someone at high risk to be a score of 10 or more. So before we headed overseas, we considered, let's have a little look, a little research fiddle, see how this lace, whether it would work for us or not. We only had a small sample of 202 patients, but when we looked at this, we decided that, yeah, it was very similar to the original study by Gruner and his mates in Canada, with those with a score of greater than 10 were twice as likely or 3 times as likely to represent. So complex care and complex planning, it's an entire health approach, and that's what I'm hearing from everyone that's spoken today. This is shared care, this is the trauma team that the Royal Melbourne's working with, it's everyone's responsibility. So respond early, perhaps using a tool to identify who may represent, acute beds for the acutely unwell, using the estimated discharge date to inform all in the team, streamline referral processes and reducing corridor conversations and good documentation. So improving representation and readmission rates and the patient journey is our goal, everyone's goal, I'm sure. With the LACE, Irfan Dalia and his team at Toronto then used it to direct people through a random controlled trial that he's just winding up now, incorporating all those siloed community programs into one program. He admitted patients from inpatient and ED with patients that the LACE score was 10 or higher. So it had medical direction, pharmacy, care coordinators, patient education, and then they were discharged at 4 to 6 weeks. The results, I believe, aren't out yet. So I thought, when I was invited to this, how could this sort of mould to the surgical audience that is here today? And one of the executives said to me, I've just heard about this guy that's up in the vascular clinic. So he's a 31-year-old fellow, so needing attention by the vascular team. His comorbidities, he's a diabetic, type 1, peripheral neuropathy and poor renal function. Involved with the medical clinic to get that renal function happening before he needed surgery. He'd had 3 ED presentations recently to that. Unemployed because of his mobility issues, and of course there's family stresses and related financial pressures. So I asked myself, could a risk prediction tool be applied at the pre-admission clinic to this fellow that might just titrate and target our valuable resources to the people that needed him, that were needed? It's just a thought. But this fellow's LACE score without his length of stay actually came to 9. And remember that the top score where he's at high risk is 10. And that's it from me.